Hello, I'm Dr. Jerome Kim, the Director General of the International Vaccine Institute, located in Seoul, South Korea. I'm honored for the invitation to present at the Global Conference for the Unification of the Korean Peninsula on the consequences of vaccine inequity in the Korean Peninsula and the world. These are my disclosures. This is where we are in January of 2022. What you see in the map in green are countries that have achieved 100% use of vaccines in their population. So this does not necessarily mean that 100% of the population has been vaccinated, simply that the number of doses equals the population. That would be 100%. So you can see that a good part of the world is green. You can notice Korea in Northeast Asia, next to it South Korea, next to it North Korea, which is gray, meaning that there is no data. There are no data. So as of January 6th, 58%, almost 60% of the world has received at least one dose of a COVID-19 vaccine. 9.3 billion doses have been administered to date, but still 8.5% of people living in low-income countries have received a dose of COVID-19 vaccine, which implies that 91.5% of those people have not received COVID-19 vaccination. And despite this effort at vaccination, as of the 6th of January, almost 300 million COVID infections have occurred and 5.5 million deaths. So a tremendous toll in infections and death. We owe a lot to innovation. Innovation that got us vaccines with a proof of concept, proof of efficacy and safety within 11 months. Around the world, there are 32 different vaccines approved by different regulatory bodies. Of those, 10 of the vaccines have received World Health Organization emergency use listing, which allows them to be purchased for global health and importantly allows them to be a part of the supply of vaccine distributed by the global facility known as COVAX. There have been 170 vaccine candidates, 555 vaccine trials, and vaccine trials conducted in 62 countries. And you can see the pipeline of vaccines in phase 1 of clinical trials, phase 2, phase 3, and the 32 vaccines, of course, that I mentioned were approved. Of these new vaccines, we've seen a remarkable development. We've never before had mRNA vaccines. We haven't extensively used, actually, in the past, there had only been one very infrequently used adenoviral vector vaccine for Ebola. We'd never had an approved DNA vaccine. And we've had the use of new adjuvants, which have greatly extended our ability to potentiate, to improve immune responses to vaccine antigens. So really remarkable progress and a lot of innovation as a result of the COVID-19 crisis. But where are we? Proving that a vaccine was safe and efficacious was almost the easiest task. The next step, making enough of vaccine, proved to be a little more problematic. In the beginning of 2021, UNICEF asked companies with COVID-19 vaccines in their pipeline how much vaccine they could make over the course of the year. And you can see that in the first half of 2021, companies claimed that they could make 7.2 billion doses. And in the second half, through 2021, the companies thought they might be able to make 12.6 billion doses of vaccine. Now, in fact, the IFPMA reports that manufacturers are making between 1.5 and 2 billion doses of COVID vaccines a year. This is as of September 2021. So they're probably making more now, with additional vaccines being approved by the World Health Organization. However, reality has been a little bit different, and we're about 3 billion doses short of that 12.6 billion dose total. What you see here are the vaccines that are in common use: RNA vaccines, whole inactivated virus vaccines, protein subunit vaccines, where the orders have been given and what the projected orders are by company. And you can see them all listed here. So we fell a bit short of the 12.6 billion doses projected, but with 9 billion doses made, we are 20-fold higher for COVID-19 vaccines than for any other vaccine in common use. This would include BCG vaccine and influenza vaccine made by a dozen or so different manufacturers. So a lot of COVID-19 vaccines have been made, but not enough. But this misses a key point, and that is that the use of vaccine is extraordinarily dependent on the wealth of a country. What you see in this chart here is per capita income on the x-axis and use of vaccine on the y-axis. And you can see that as income increases, vaccination increases. And as income is lower, vaccination is lower in orange. And the poorest countries shown here are those that have the greatest vaccination gap. So the equity gap has been a real problem for COVID-19 vaccines. Initially for the supply and use of the vaccines, and you'll see more of that later. But the first equity gap, the biggest equity gap, the one that we dealt with in 2021, was a gap in vaccine supply. But this isn't unusual. This happens with almost every global health vaccine. What you see here is data from rotavirus vaccine. So rotavirus vaccine, which works against, it's a pediatric vaccine for rotavirus diarrhea, was approved by the US FDA in 2006. By 2009, rotavirus diarrhea had almost disappeared from the United States. WHO approved rotavirus vaccine in 2009, made a recommendation for its use in 2009. And in 2021, about 100 countries around the world have rotavirus vaccine on their national vaccination programs. However, in 2021, 60% of the world's children still have not received a full course of rotavirus vaccination. So it takes decades for vaccines typically to make their way from high-income countries where they're discovered and developed and tested to lower-income countries where the vaccines have profound impact on the burden of disease and death. With COVID-19, though, we didn't have the luxury of time. We know that uncontrolled outbreaks of COVID-19 have consequences beyond infection, disease, and death. And we'll go into those in a second, but we also know that these uncontrolled outbreaks are the source of variants. And variants have the potential to undermine all the progress that we've made in COVID-19 vaccine development. So in response to this apparent gap, the WHO, Gavi, and CEPI, the Coalition for Epidemic Preparedness Innovations, organized a group of 190 countries into the COVAX facility. COVAX intended to supply 92 of these 190 countries with no-cost or low-cost vaccine. It intended to have 2 billion doses of WHO emergency use listed vaccines distributed by the end of 2021. They had secured a total of almost 6 billion doses of vaccine. Now, clearly, this isn't enough. 2 billion doses covers about 20% of a country's population, but it would allow the country to vaccinate the population at greatest risk for bad outcome, the elderly, and a population at tremendous risk for acquiring the disease and potentially spreading it to others. That would be healthcare workers. So COVAX was a unique opportunity for the world to bring innovative vaccine technology to populations at great risk within the first year of approval of that technology, a really remarkable feat if it could be a bridge to near concurrent access. Or unfortunately, was it a bridge too far? By the end of 2021, under 1 billion doses had been shipped, so less than 50%, but in point of fact, to 144 countries around the world. We know that the failure, or we had predicted, the failure of access and equity would have consequences. And what you see here, humanitarian, economic, and biological, are the consequences that were predicted that came true. The humanitarian consequence. The Gates Foundation modeling suggested that without equity in the distribution of the first 2 billion doses of global COVID-19 vaccine, deaths would double. That prediction was made in June of 2020, when the total number of deaths was 431,000. By the 3rd of November 2021, deaths were 5 million. So we had really seen the consequence of the lack of equity and the lack of supply of vaccine globally. The second consequence was economic, and that is that without equity, 50% of the global cost of the pandemic in 2021, which is about $4 to $5 trillion, would be borne by high-income countries. And these were data from the National Board of Economic Review, the Brookings Institute, and interestingly, the Office of National Intelligence, which is the part of the US government sitting in the White House that advises the president about the President of the United States, about issues of importance, of great concern globally. The third consequence is biological, and that is that we know that outbreaks generate variants and that variants generate outbreaks, and failure to control pandemic outbreaks generates mutants, and these mutants have the potential to undermine the efficacy of vaccines, as Delta nearly did, and then now as Omicron has certainly shown that it's capable of doing. So we need to provide vaccine. We need to provide equity in the distribution of vaccine. We need to prevent outbreaks. We need to do something to reduce the burden of hospitalization and death as a result of COVID-19. So this gives you an illustration of where COVAX hoped to be in orange in the year 2021, where they were up through June in purple, where they projected they might be, revised projections, by the end of the year. Now, in fact, COVAX distributed under 1 billion doses, so they were about 50% below their original projection and about 75% below their revised projection. Now, there were lots of reasons for this. There were issues with supply and approvals of vaccine, with delivery of contracts on time, with the availability of funding and what funding could be used for what purpose. And then, of course, there were, by the end of the year, emerging evidence of failures in logistics and implementation, which we all knew was going to be a problem, because not only do you have to prove a vaccine works and make the vaccine, but you have to prove that you can use it. Vaccine itself does not save lives. Vaccination saves lives. So now let's go to the three equity gaps. We've discussed the first gap, the vaccine supply gap, early on. And these are just cartoons that illustrate that the rich countries got what they needed, a vaccine to fight against COVID. The poor countries, of course, did not. Vaccines came faster to wealthy countries with money than to poorer countries without the funding. So that underlines the equity gap in supply. But there was also a qualitative gap. If you look at high-income countries, they were able to use much more RNA vaccine in orange than even the upper middle income countries, which used a lot more of the viral vector vaccines, so the adenoviral vector vaccines, and the lower middle income countries, which again now are showing greater and greater proportion of vaccine that is whole inactivated. That is one of the two Chinese vaccines, Sinopharm or Sinovac, or now the Indian vaccine from Bharat. COVAX supply, again, is viral vector, some RNA, but a lot of other vaccines, including the whole inactivated virus vaccines. The second gap is an implementation gap. And this gets to some of the challenges associated not with vaccine supply, but with using that vaccine appropriately. So remember that if everybody in the world gets 2 billion doses, we need 16 billion doses of vaccine. And if everyone needs a booster every 6 months, that's an additional 8 billion doses and an additional 8 billion doses every 6 months, which could be unsustainable. The issue here is that, we do a pretty good job of vaccinating the birth cohort. So the children who are born every year, 130 million of them, 80 to 85% of them get the vaccines they're supposed to get in the extended program of immunization that WHO has convinced countries to undertake. Really a remarkable achievement for 130 million infants a year. But now we go from an EPI, extended program of immunization, to universal immunization of 8 billion people, and you can see the issues that would create. Of course, there's the logistics. It would take 8,000 jumbo jets just to fly 8 billion doses around the world. So now we're thinking 16,000 747s for 2 doses. Some of the vaccine needed to be kept at -70 or at least at -20. Again, how do we keep ultra cold temperatures on a plane with pallets of cargo? How do we track and record the use of vaccine? Just the supplies to administer vaccines, face shields, gloves, syringes, needles, weigh more than the vials themselves. And how do we dispose of this medical waste? And where are we going to put it all in countries where waste disposal may be a burn pit or a place of convenience somewhere around the neighborhood? There's going to be an access problem, as people who make $1 a day and barely feed their families are now going to be asked to take off work to attend vaccination at a vaccination campaign site. How do we deal with the access problem? What about the overworked staff who are already overburdened by COVID-19 healthcare? now having to take time out, not only to do the normal pediatric vaccinations, but to vaccinate all the adults and the other children within their areas of responsibility. So having personnel to be able to give these vaccines is going to be a tremendous problem. What about vaccine wastage? And we're already seeing and hearing reports, some of them anecdotal, about countries wasting hundreds of millions of doses, disposing of them because they just can't be used. The Tony Blair Institute for Social Change published a white paper in August of 2021, if you're interested, on the absorption capacity challenge. So absorptive capacity is our ability not only to have vaccine, but to use vaccine. And increasingly in 2022, vaccination will be the issue, not vaccine supply. This gets to the point that delivery is not the only, that supply of vaccine is not the only concern. So what you have on the upper panel are countries where there are below average vaccination rates. And so the question is, so what is responsible for those below average vaccination rates? And what you can see is that some of the countries have a low vaccination rate, but a high utilization of all the doses that they have. And so you can see here, Mozambique is one, Pakistan is another, India is another. So all the vaccine that they get is being used. On the other hand, you have countries with low vaccination rates that are not using all their vaccine. And this would suggest weak demand, either through hesitancy, loss of faith in vaccines, lack of trust in the government, or politics, or not having the appropriate infrastructure, that is physical infrastructure or human infrastructure. And we could have planned in the 2 years it took to roll this out to have strengthened the human and physical infrastructure that would deliver 8 billion doses of vaccine to people around the world. The third gap is the diagnostics and sequencing gap. What you see here are the number of daily tests per 100,000 population in high-income countries in blue and in low-income countries way down here on the baseline in green. But the difference in diagnostics could also explain what we're seeing now as we're doing vaccine trials in low-income countries. Significant portions of the population, 50 to 70%, have evidence of prior COVID infection. Yet when we looked at the charts of where COVID infections were, we did not see evidence of significant COVID infections in Africa. We didn't see evidence of significant COVID deaths in Africa, but as more countries roll out data, like South Africa being one of them, the number of COVID-19 related deaths is probably significantly underreported. The diagnostics gap is estimated at $2 billion in a study by the PDP known as FIND and the WHO. And it really will impair our ability to know where vaccine is needed. It will impair our ability to know where outbreaks are occurring. And importantly, the second part of that is a sequencing gap. In the month before Omicron was discovered, so in the October to November timeframe, Africa submitted 200 full-length sequences to the global sequencing database known as GISAID, G-I-S-A-I-D. At the same time, Europe submitted 171,000 full-length sequences, and North America contributed about 70,000 full-length sequences. Luckily, we had good scientists in South Africa who identified the Omicron variant and really emphasized what it was doing in certain areas, in certain districts in South Africa, and the world became aware. But the sequencing gap means that not only do we not know, the sequencing and diagnostics gap mean that not only do we not know where the outbreaks are occurring, but we don't know what variants are causing those outbreaks. So we're trying to fight a battle blind. And the final point here gets to now that we have oral drugs that are effective antivirals, drugs like Paxlovid, that should only be used in the presence of a known infection with COVID-19. The diagnostics gap becomes critical because we cannot then treat people whom we don't know have COVID or not. So now COVID-19 in the Korean Peninsula. You can see North Korea, and this is the vaccination map again, is gray. No data are available. Clearly, DPRK said foreign-made vaccines are, quote, not a panacea to all problems. They objected to the reporting requirements for COVAX. They rejected Sinovac vaccine from COVAX. They've also rejected Sputnik 5 vaccines. Now, is this because DPRK would like to see RNA vaccines offered? Perhaps, but we don't know. Is it that the DPRK has not invested in vaccine infrastructure? Now, IVI has done some vaccination using Japanese encephalitis vaccine in North Korea, and those vaccinations were very efficient. Were there safety concerns that highlighted that the government felt would decrease credibility for the vaccines or for the government? Again, we don't know. We have very little information on the COVID-19 pandemic in North Korea, or the reasons why the government is rejecting the use of vaccines that are offered through the COVAX facility. As a counterpoint, we have in the Republic of Korea, 83% of people fully vaccinated, 86% of people receiving at least one dose, and 38%, nearly 40% of people being boosted. But what are the real consequences then of inequity on the Korean Peninsula? Well, we don't know what the status of COVID-19 is in North Korea. But assuming that there is a big outbreak there, the isolation that North Korea has enforced upon itself due to COVID-19 may prevent those outbreaks from spreading. It will not prevent the emergence of mutants, and those mutants could have dramatic consequences for neighboring countries. UN officials, now this is United Nations, were warning of a dire shortage of food in North Korea, and chronic food shortages were noted by Kim Jong-un at a Central Committee meeting at the end of December. Could COVID-19 exacerbate an already existing crisis in food supply? Yes. What do we really know? Not enough. So finally, what are the risks of the pandemic further destabilizing the situation in North Korea or between the Koreas? Again, difficult to know because of a lack of information around North Korea. Should North Korea vaccinate its population? Absolutely. Will vaccines have a beneficial effect on a pandemic in North Korea as it did in South Korea, as it has in countries around the world? Absolutely. Should we do things within our power to try and get vaccine to North Korea? Yes. So thank you very much. You know, IVI has worked with over 26 companies, organizations, universities, and philanthropies to accelerate COVID-19 vaccine access. And we did that by working in every aspect of what IVI does, in animal studies, in human clinical studies, in effectiveness trials, and in capacity building in sites around the world. And for us, that is the most important contribution we can make. Companies that IVI is working with have committed 1 billion doses to the COVAX facility. And by doing that, we hope that IVI will meet its vision of a world free from suffering from vaccine-preventable infectious diseases, in this case applied to COVID. Thanks again.